All right, thank you guys for logging in today. Corey and I are doing our version of Zoomin live today from the U's. We've got about 10 to 12 residents in the room, and we've got a choose your own case conference, which we're going to go to. We've got a expert discussant in the room with us today. I'm not going to reveal who it is for the people who are not here, but he is one of our ICU attendees and has sort of a special role in the ICU in the pulmonary department. So let's get started. So our journey begins, and because this is a choose your own conference, you guys sort of have 3 different paths which you can travel through this conference. And so for the people in the room, go ahead and pick which one of these images you would like to start with.
Seattle.
Cool. So we hear Space Needle. The people in the room, I think we have some people from Seattle, so that was probably a good one. All right, so we're gonna start with Space Needle in Seattle. Okay. So first case is chief complaint is going to be shortness of breath and chest pain. So your HPI, this is a 65-year-old man coming in with a sudden onset of chest pain, dyspnea, and nausea. Pain is worse with deep breaths. He reports trouble catching his breath and says that he had surgery on his foot about a month prior to presentation. And since then, he's essentially been immobile in his house with a cast on his right leg. So past history, he had a right foot surgery 1 month ago, so he has a cast on, or had a cast on, and was immobilized. He's got no significant alcohol, tobacco, or drug use, and that's it. All right, so into our workup, because this is going to be sort of quick hitters. He's afebrile, pressure's 129/75. He's tachycardic to 133, breathing 30 times per minute, and sat in 87% on room air. On exam, he's in no acute distress, but he is in respiratory distress with 3-word dyspnea. His lungs are clear. And then he's got swelling in both legs with no symmetric and no tenderness, and he says this is sort of chronic for him. He gets some labs back. His CBC is essentially normal. His BNP is essentially normal. His other labs are not. So his troponin's a little bit elevated. His DNP is 272. His D-dimer is 3,000, and his EKG is sinus 10. All right, so for the residents in the room, go ahead and give me a quick differential for what you guys think is going on with this person. So 1 is PE, perfect. And can we be any more specific than just PE? PE, we're invoking, maybe this is a submassive PE. Awesome. Anything else you guys are thinking about right now? He is not having any wheezing, but what would that sort of invoke? Great, so COPD. I think based on how emphatic that first answer was, maybe a little bit lower than our first choice, but it's still certainly a good thing to consider. Great. So Claire's also saying pneumothorax for sort of the chest pain, the respiratory distress. Like, okay. So you guys think he's got a PE, a COPD, or a pneumothorax? What diagnostic study do you want to order next?
CT.
All right, we've got a CTPE from Matt Rockstrom. So up on the screen, you're going to see the CTPE. We're going to run through it, and then I'm going to ask one of our residents in the room to give us sort of their really quick read on the CT.
Oh.
Positive gasp sign from the audience. We're going to run through it one more time just to make sure people saw the abnormality. So, Matt Rockstrom, one of our second years, what are you seeing on the CT?
So, the non-obstructive saddle with evidence of pulmonary artery dilation.
I like it. Peter Hountras, anything you would like to add?
Yeah, I think the biggest thing, again, when we're looking at this, we want to make sure that the contrast is well timed, right? So that's the whole idea. We don't just give contrast. So if you send somebody down for a CT check with contrast, right, you're not really going to be able to tell for sure if they do or don't have PE, especially outside of the central, because there's a timing aspect to when we deliver the contrast and when we start taking the pictures, right? So that matters. Number two, so we've got this saddle embolus, right? So saddle really just means that it's kind of coming across and going on both sides of the pulmonary arteries. I know that when I was in training and in med school and residency, that always not only makes me twinge a little bit about what's going on with this patient, but almost always in my mind that associated with bad things are potentially going to happen. Not always the case. The longer I've been doing this, I will tell you that we've had patients come in with saddle emboli that are otherwise low risk, and the scariest thing about them is their pictures. And then obviously as you're going down and talking about what's going on with this patient, wanting to look for what we call those filling defects that Danny's done a great job as far as outlining there, right? And so that idea is that we're going on and going down into the images, whether it's this patient or the other one, looking to see where are they located, and mainly from a perspective of if we think that this patient is going to need advanced procedures, which we'll talk about in a little bit, that location plays a role, right? So things that are more centrally located are going to give the patient a lot more options than things that are more distally located. Number, size, bilateral, unilateral, it doesn't really matter. That's a cool thing that sometimes we talk about with patients. But in overall scheme of things, as far as how its effect on the heart, doesn't matter as much. There was a good comment made about the size of the PA, which is good. And then if you can scroll down a little bit so we can take a look at the other thing we need to take a look at, right, is looking at the RV. So we have evidence of submassive because right there. We have evidence of submassive based on our laboratory data, right? So our troponin and our BNP were both elevated. But the other thing you want to look at is for imaging, showing that's what's going on. And so CT scan and echo are our two primary modes of imaging, right? So in this situation, what do you guys think about the RV compared to the LV? It's almost bigger, if not the same size, right? So, and then normally the RV is supposed to be, a third the size of the LV, right? So if you're at, I'm not a cardiologist, but I can definitely tell when the RV is almost the same size, if not bigger than the LV. Like that's an obvious thing to me. I don't need somebody to tell me that. So in this situation, there's definitely RV dilatation and evidence of RV probably dysfunction and again that whole understanding of submassive going on.
That's why we have experts in the room. So perfect. So what Matt and Dr. Hountras both talked about to some degree is saddle PE. So here's the representative image with that enlarged pulmonary artery as well. And you can see it in the main PA, but then branching into the right and left. And then the other thing that Dr. Hountras just mentioned was sort of evidence of right heart strain on CT. And so like we talked about, the RV is basically larger than the LV, if not the same size. And then we also have reflux of contrast into the IVC. And so if you look down here at the bottom, you can see this white spot here on the image right there shows that the contrast that you pushed in reflux backwards. And so essentially the right heart is not pumping as much forward as it should. And so this is one of those things you get for free on your CT scan that we often don't think about as much. All right, so we've got evidence of right heart strain. We've got some elevated biomarkers. So let's talk for a second about this sort of spectrum of PE. So as one of our upper level residents in the room want to give us sort of their idea or sort of how they approach PE in terms of diagnosis.
Like stratifying them. Yeah. So I think about low risk, submassive, and massive. Low risk being the presence of PE without any evidence of right heart strain, cardiac biomarkers, imaging findings indicative, either on echo or CT, like we just discussed. If you do have something suggestive of right heart strain, biomarkers or otherwise, without hemodynamic instability, then submassive, and then massive is the presence of shock, basically, or hypotension.
Awesome. That's a great, really quick rundown. And so, right, we're always thinking about this stuff when we admit someone with PE, but essentially, do they have another abnormality, or is it just a low-risk PE? Dr. Hanley, one of our attendings at Denver Health, describes that as like the med student PE, like the classic PE that anyone should be able to pick up based on history. Submassive, like Matt mentioned, you get biomarkers, so trope, BNP, EKG changes, or sort of any evidence of RV strain without hemodynamic instability. And then when we talk about hemodynamic instability, certainly shock qualifies, but does anyone else know the other criteria which meets hemodynamic instability?
Non-responsive fluids.
Okay, so not responsive to fluid, so if you sort of were hypotensive and it never came up, absolutely. And then one of the criteria with the blood pressure, so the person may not necessarily be hypotensive, but their pressure will be different than their baseline. Does anyone remember that sort of magic number? So if your systolic is less than 40, or sort of actually, I said that first, your systolic is greater than 40 from your baseline. And so if you're walking around with a pressure of 180 at baseline and you come in with a systolic of 120, you've technically met criteria for a massive pulmonary embolus. And this stuff matters because we're going to talk about in a second, the way we treat massive PE and submassive PE and low-risk PEs is substantially different.
I think the one thing that I would, and I don't know if Danny is going to specifically get into echo about when we talk about echo.
Go ahead.
Or no, if we
No,
are.
go ahead.
So obviously echo, right? So a lot of times you'll hear, we'll get involved as part of the PERT team and consult along with patients. You guys will be getting an echo, especially in somebody that's got submassive features. When we take a look and we look at the echocardiograms, and we see the RVs big, we see that there's increased pressures, and the echo reader is obviously calling and saying this person may have moderate, severe pulmonary hypertension, right? So remembering that in the setting of acute PE, the person doesn't have PH, this person has acute PE with RV dysfunction, right? So you're not calling somebody having pulmonary hypertension in the setting of, no matter what the number is. Unless that we think that this is maybe an acute on chronic situation, right, where we think that maybe this person's had a PE before, and there's some evidence on the CT scan that there's some of this could be chronic scarring, and that we're wondering if there's some CTAP. No matter what, everything that's happening in that heat window and for the next 3 months is going to be attributed to that clot until we prove that the clot's had enough time to try and resolve, and so that's not.
Perfect. All right, so Dr. Hountras is alluding to a lot of really, really excellent points here. So let's go back to our PowerPoint. So this is the echo now for this gentleman, like we just talked about. So I'm going to play the echo, and then I'm going to have one of our upper levels give me a shot at what they see going on. This is your parasternal short view. I'll play that one more time for the people watching. So again, this is the parasternal short view for the patient. All right, so one of our upper levels, all right, so we've got Anita just going for it in the comments. I like it. So Anita says this is the D sign, and she is exactly correct. So this is the D sign. So if you look at their echo, you can see that, let me just annotate this for you guys real quick. So if you look at the echo, this right here is the RV, and this is the LV, and this area right here is the septum. And so what you can see is there's septal flattening, and then if you superimpose a D on top of that, essentially if you make yourself think it looks like a D. And the D sign is suggestive of RV volume and pressure overload, impeding the LV filling, essentially. And so this is why people go into obstructive shock from PE, is that if their LV is not able to fill because of an enlarged RV, they decrease their cardiac output and they go into shock. So this is a great example of the D sign on a parasternal short. Again, I would not make a clinical decision as a resident on looking at someone's echo at the bedside. This is something a pulmonary fellow or a pulmonary attending should help with. All right, and then here is going to be the apical 4 chamber for this patient as well. It's not the most classic view for it, but still pretty representative. All right, so we'll say, let's do an intern for this one. Jay, tell me, starting sort of left to right, just name the structures you're looking at right now.
Good. All right. On the left side, we have our right ventricle, and then to the right, we have our left ventricle, and then below, I guess we probably have what I guess is our right atrium below the right ventricle, and same thing for our left.
Great. Yeah, so Jake's exactly right. So you've got your RV, your LV, right atrium, left atrium, sort of going in a clockwise fashion. And anyone in the room just call it out. What's really notable about this echo?
Hypodynamic RV, loss of bowing, intraseptal bowing.
Yeah, perfect. So the RV is not moving a lot, and it's just humongous, right? It's like a balloon. It's blown up. And I think if you were like a medical student or not as good at echo as someone else, you might think that the image was reversed, and you might think that that LV is actually on the left side. And then I think that is, Ellen Murray brings up McConnell sign. So did this gentleman have McConnell sign? I'll let Ellen see if she wants to type into the chat what McConnell sign is, but does anyone in the room know what McConnell sign is?
Typical objectivity, and we have lost the central motion making.
Peter, you get that right?
Yeah.
Perfect. Yeah, so if you look at this right here, so you can see this person actually did not have McConnell sign because their apex was not moving great, but it's exactly right. So essentially you have sort of preservation of this area up here, and then you have sort of loss of motion of the free wall right there.
On a classic, it almost looks like if you've got the perfect chamber view that like somebody's got their finger on the apex of the heart and is like pushing down to the top of the right ventricle, almost like making it in dead. And the rest of the right ventricle is not moving whatsoever. I think that the big thing to know and to think about anytime you guys are obtaining images, and I want to encourage you guys, grab the ultrasound, grab your fellow, grab your attending, go and look for these things. And we need to make sure that we're doing a good job of being in the right place in the right windows. Otherwise, we can trick ourselves into thinking that there's problems when there aren't. Again, I think that these images are okay. You can see that as he's probably going into respiration, I think we're getting better and worse images as he's breathing. Because in theory, and wanting to make sure that we're calling the right things on an apical four-chamber view, you want to be able to see both ventricles, see both atria, and see the valves. And so if you're not in a situation where you're seeing all the structures you need to see, you may be calling things or off axis in a way, and you're saying, oh, well, that right ventricle is huge, when in reality, you're just rotated in a funny way that's making it look like that based on the shadows and the things that are bouncing back to the throat. So we got to be very careful in what situations we're doing it. And again, making sure you're grabbing somebody doing it, get in there, try to get the information, because this is quick, very easy stuff that we can do at the bedside. We're wanting to make sure that we're making clinical judgments off the right thing.
Question 2, utility of an echo after you already have established some asset PE.
Talk about it in a second. It's a great question. So that is a perfect segue into who you're going to call. So interns, we'll defer to you guys on this one. What 2 services, I'll give you 2 services here, 1 consult and 1 service that you're going to give a call to, pretending you're the ER intern or ER resident. That's a broad question. So admission location, where do you guys want to put this gentleman? Okay, so we've got ICU, and then what service do you want to call as a consult? And if you don't know the answer, that's great, because that's also the purpose of this conference. Great. Claire, who else do you want to call?
I'll call the PERT team.
The PERT team. So the PERT team is redundant, because its T is the actual T. But yeah, so you want to call the PERT, so the Pulmonary Embolism Response Team, or if you're saying PERT team, the PE Response Team. And so this is what it looks like in Epic when you order a consult to the PERT. Essentially, you just type in PERT or type in PE. There's my name. I did not put a consult in because I'm not sure I can practice medicine right now. You type in your consult, so submassive PE or concern or whatever, and then you also call the PERT fellow or consult fellow in Epic for pulmonary and tell them the story. And so, why do we need a PERT team? Does anyone know?
Sometimes it showed like reduced mortality, like a multimodal and like multi-pulmonary approach to at least some messages.
Perfect. So what Jake said was that there's been some studies showing reduced mortality when you have sort of a multidisciplinary approach. And then the evidence surrounding submassive PE is just really confusing for non-pulmonologists. And so there's been a few studies. So you've got PICO from 2014, Seattle 2 around that same time, and then a study Ultima also from around that same time. And because we had one of the leaders of the PERT in the room with us, Dr. Hountras, I'm going to defer to him to tell us sort of why PERT, and then sort of his sort of brief takeaway from these studies and what the PERT provides.
Yeah, so great questions, and I'm thankful to be able to be here to talk about this. And anybody that has more questions, we can talk about it in more detailed time later. But in reality, as we talked about before, I think PE has had a lot of research that has happened in my time since med school and graduating at that in 2011, which is really how long ago that was. And the data is kind of confusing, and especially around submassive, there's a lot of opinion and not a lot of fact, and we'll kind of get into that as we talk about what the appropriate thing is to think about doing for these patients. And so in reality, what's happened over the last 10 years is that some institutions, I think starting with Mass Gen in Boston, created a team of doctors that really enjoyed taking care of patients with clot. And that included cardiologists, pulmonologists, interventional radiologists, CT surgeons, hematologists, and kind of all came together with the idea and the understanding that when we get calls about these patients that we're still not really sure what to do with, maybe it'd be better if we were the ones that kind of got in and we're trying to help make some of these decisions so that we can make it quicker, so that way we're developing our own set of guidelines and algorithms as far as how we take care of these patients and then trying to look at outcomes down the road. And the interesting thing is for some of these studies, it's very hard to be able to tell how much of the difference in the outcome is because the PERT team got involved versus how much of the difference is actually some of the procedural or the medical applications that were being given to some of these patients. And regardless of which, you know, the data that even just came out this last year, I think it was in January 2020, looking at from some of the Cleveland Clinic guys, is that based on using the PERT team, they've seen decreasing length of hospital stay, decreasing ICU admissions, quicker time to the appropriate anticoagulation, less IVC filter placement, like all these things that we all think are great and wonderful, getting the patient to the right spot and then getting them out of the hospital and having appropriate follow-up as far as things going forward.
Perfect, that's great. Yeah, and the reason is those studies that we just talked about, Seattle and Ultimo, those were sort of industry-funded catheter studies looking at like ultrasound catheters where they put TPA right into the pulmonary artery. And the outcomes there were sort of decreased RV size, improved hemodynamics, but Peter, correct me if I'm wrong, my understanding, no change in mortality for those studies?
Correct, yeah. So the overall arching look at, for some of these studies, when we specifically look at catheter-based studies, right, that's the fancy thing, that's the sexy thing, if I'm going to stick a catheter somewhere and drop TPA, or use a catheter to try and suck some of these things out, and we're not even going to get to those today, just because that's a little bit out of our scope. But the studies for the last 5 years that have kind of been hitting the mark are the ones looking at, well, if I take a patient, you may not be the best candidate for giving them systemic TPA. You may not even qualify necessarily for systemic TPA. And I take them to the cath lab and I go in and I essentially take these really large tubes, stick them into right where the clot is, use this special fancy probe that has ultrasound that supposedly helps break up the fibrin strands, which is another whole deal, and then shoots out TPA into the clot, but maybe that in itself is going to improve patient outcomes, right? And so what they did is they had to pick a primary endpoint. The primary endpoint that they chose, as Danny was alluding to, was change in RV to LV size, right? And so that was based on a study that prospectively looked at patients that had PE, comparing patients that had an abnormal RV to LV ratio to ones that had a normal one on CT scan, and the ones that had an abnormal one had increased morbidity and mortality going forward compared to the ones that didn't. So they're like, okay, well, maybe we'll target this. If we target this and it gets better, then we've done something and made these things better. And that was the Ultima study, was the first one that came out with that. And that's the only randomized trial that we have. Again, it's not a randomized placebo-controlled trial because there was no sham study as far as the procedure, but at least it was randomized. Randomized to either getting the catheterectomy or getting standard of care, which was just anticoagulation. And what they found was in 48 hours, the RV to LV ratio improved quicker in patients that had the procedure done. Their RV function was no different at the time. And then when they went out to 90 days and they compared both groups again, there was no difference between the group that just got anticoagulation and the group that got anticoagulation plus the catheterectomy. And so for the people that really like doing procedures, that was a huge win for them. They're like, all right, we're doing something better. Let's do these procedures. Let's get patients into the cath lab. We're going to make them better. However, again, somewhere in that 90-day window, I don't know if it's at day 5 or day 29, patients that just got anticoagulation alone caught up. There was no difference in mortality. Now, that was a primary endpoint. No difference in people getting CTEPH. None of those things. The only difference was in that first 48 hours. When we go to Seattle 2, which was kind of a follow-up to that study was actually not even a randomized controlled trial. That study was purely looking at dosing and timing of using catheter electrolytics and saying there's a high dose and a low dose. Are they kind of equal? Can we get away with a lower dose than a higher dose of TPA? Didn't compare it to anybody. And of course, when you don't compare it to anything, it looks good, right? RV to LV ratio gets better. PVR gets better. And so that was kind of that one. And then the last study that Danny brought up that I think is important to look at is the PERT study. It's a really good study to read. And this was actually looking at, well, we give systemic lytics for patients that have massive PE, and we'll probably talk about that down one of our other paths. But this is looking at giving systemic lytics for patients with submassive PE. So like, well, if it works for massive, maybe it'll work for submassive. And so they actually tried using a drug called tenecteplase, which is not a drug that we use for taking care of pulmonary embolisms, but is similar to TPA. And they effectively said, well, if we have somebody that's got submassive PE, we're going to give them this, and we're going to see as a primary endpoint to see if there's a change in death or hemodynamic decompensation at 7 days. And that was a composite endpoint. So it wasn't just death, and it wasn't just hemodynamic decompensation, it was both. And what they found was that there was a positive endpoint. And so everybody at first was like, yay, this sounds great. But when you teased it out, really the positive endpoint was being driven by hemodynamic decompensation, not by mortality change. And so then when you go and say, okay, well, you're improving hemodynamics, what are we doing for bleeding? There was a much higher bleeding risk in the patients that were getting tenecteplase, including things like intracerebral hemorrhage. And so not a great idea.
Not great. All right, that was awesome. So case continued. Patient was started on a heparin drip, transitioned to Lovenox in the morning, and the PERT team was called. Transporters were placed for the floor because the patient was improving. When on hospital day 2, he stood up and had a near syncopal event while ambulating to the bathroom, required heated high flow to maintain an oxygen saturation above 90%. And everyone in the NICU ran to this person's room at the exact same time. So, for our team in the room, what medicine should you be asking the pharmacist to pull for you right now? TPA, great. So we'll talk about this much more in another case, but patient received alteplase or TPA, 100 milligrams, so the full dose for management of what the team was concerned about was a new massive pulmonary embolism from sort of dislodgement of his lower extremity DVT or migration of his current PE.
Can I ask you a question about the heparin drip to Lovenox? Like, if we're thinking there's a possibility we might go to IR, would you do a heparin drip, or is it generally okay in some massive people that just start on Lovenox?
Great question. So we actually prefer doing Lovenox now over heparin drip unless somebody actually can't get Lovenox for some reason, usually renal failure being really the only one. And the main reason is, one, your quicker time to therapeutic action, right? So like with the heparin, I can give a bolus, it still may take time to get their PTT or their 10A or whatever level we're following to where they want to be, versus with Lovenox, I dose them, 1 mg per kg BID, I give them that first shot, and once that gets into their system, it's going to be active and moving in the right direction. From our standpoint and our interventional radiologist, there is no contraindication to them getting the Lovenox and going for a procedure if they still need it. So our recommendation is our first shot should be doing a low molecular weight heparin unless they have it.
Great question, Claire. All right, so the journey continues. That was our first case, and that was by far the longest one. So we've got 2 left, and so if you didn't know, that's the Space Needle, iconic Seattle monument. That rocks from This Isn't Dearly. We got 2 more pictures, though. So the room, take your next pick.
I'm gonna go with other things Matt Rockstrom likes and go with the
Does anyone know what mountain this is? Or an educated guess, if we just talked about submassive PE, what might we talk about next? Mount Massive. And what city is Mount Massive located next to? Oh, it's located next to Lebanon. That's wonderful. This is why me and Corey get paid so much. Tons based on this.
That's why he gets
So,
paid.
50-year-old woman with acute onset dyspnea 1 week prior to presentation. On the day of presentation, she developed severe dyspnea on exertion, unable to stand and ambulate to the bathroom prior to presenting to the ER. So she had a prior clot in quotes many years ago, and she had a history of dural venous sinus thrombosis. I don't know more about that. Please don't ask me questions. She has no relevant surgical history that you know about, and she's got former smoker, 25-pack-year history, and currently using e-cigarettes. Her workup, she is afebrile. Her pressures are not great. So she was 80/48 and got more hypotensive in the ER. Her heart rate was 78, her respiratory rate was 22, and she was setting 93% on room air. Notable exam, she was tired appearing, but otherwise just had asymmetric leg swelling. Her labs, her white count was 22, her platelets were 96. Her bicarb was low, she had an AKI, which is pretty good. And these were her trope, BNP, D-dimer, and lactate. So if this is Mount Massive, what is our working diagnosis for this poor lady?
Massive.
Great, so we think she has a massive PE. And why, just to hammer that home that point, why do we think she has a massive PE?
Hypertensive, lactate.
Perfect, so she's hypotensive, she's got a lactate, she's not perfusing. And so the systolic guideline for hypotension is anything less than 90 is considered hypotension. And they have to have a systolic less than 90 for at least 15 minutes. So if they have a brief systolic less than 90, but they get fluid and they get better, that's not considered massive, but this lady persisted. All right, so here is her EKG. And so I'd like one of the interns in the room to give me sort of a really brief read of this EKG. Say Noah.
Okay.
Take it away.
Okay. Let's start with some simple stuff. So rate. 12 times 6 is 84. Yeah. So not tachycardic rhythm, or we can do some orientation. So 2 maybe upward, so normal axis. Rhythm looks like P waves in front of every QRS. So that's good, that's nice and sinus. QRS looks narrow. Let's take a look at individual bleeds. So in in V2 you have some funky stuff going on. Looks like some ST depression-y thing, and also V3 maybe. It looks like the J point's like a millivolt lower.
I like it.
Okay.
It's a great read. I like it. Just for the sake of time, but that was a really good systematic read. Do any of our upper levels want to point out, because I'm talking about PE, the biggest abnormality on this X-ray on this EKG?
Chi, I think. We've got a Q and 3 and inverted T.
Yeah, so if we're talking about PE, I think I'm obligated to at least mention this. So he has an S1, Q3, T3, which again, if you say it to any attending, they'll say it's meaningless, which it probably is, but it's indicative of right heart strain. And so if you have the right clinical context and this is new, please be concerned about some sort of right heart strain. But Noah was going to get there. I spent a lot of time on some images. All right, so this is a CT, another CT. Matt Rockstrom will not be able to read this one, and you guys already know what the diagnosis is, so feel free to point out the abnormality. All right, so what are we seeing here? Perfect, bilateral clot. So this is a clot right here, this is a clot over here, and if you keep moving down, you can see that the clot, once you see what the color of a clot looks like on an echo, it becomes really, or a CT, it becomes really easy to follow that clot down. And you can see on both sides that you can basically keep following this clot into essentially every single lobe of the lung. So this is a picture of that. You've got bilateral clots in the right and left pulmonary artery. And the official impression from radiology was a large burden of PE with upstream involvement in the distal right main and distal left main PA with extension into all 5 lobes. Bedside ultrasound done by, I think, Dr. Bull, another one of our pulmonologists, showed a dilated RV, reduced RV function, and RVSP greater than 60. So like Dr. Hountras said in the first sort of case, this is not pulmonary hypertension. This is acute RV dysfunction. So when we're documenting, it's important to note that. All right, so case continued. What do you guys want to do to treat this person? Don't overthink it. Say louder. TPA, great. So she was diagnosed with a massive PE, started on a heparin drip and transferred to the NICU. The heparin drip was really not running for that long before. She received alteplase or TPA 100 milligrams with essentially improvement in her hemodynamics within about an hour, which is remarkably satisfying based on my reading of the note. And she was discharged from hospital day 8 on warfarin. And she was discharged on warfarin due to concern with her prior clot history and this dural venous sinus thrombosis. Any questions about this case?
Can I ask about echoes in PEs and when it's helpful, especially for like submassive PEs and like which patients you don't have to get them?
Sorry, that's that one time.
When to get an echo, and like what the utility of it is.
Great question. So, we sort of indirectly covered this at the beginning, but one of the really helpful things about getting an echo in PE is it helps us quantify sort of their RV dysfunction and what their initial problem is. And then another thing is that what does that say? We have a good lecture on this in June. Things we do for no reason. So there's some things we do for no reason. I would argue this is not the no reason category. An echo in PE is helpful because if you've got reduced RV function, you can get a repeat echo a few months after they get discharged from the hospital in our PE clinic. Shout out to getting a consult for that before they discharge. And essentially you can compare it. If you don't have recovery of your RV systolic function by that 3 to 6 month window, then you're higher risk for chronic thromboembolic pulmonary hypertension. And so it essentially gives you a time point to start comparing.
Okay, you're not going to change your management, but helpful really.
Exactly, and it's what the chat just said and what you're talking about becomes more apparent in our third case. But yes, if the person is going to be in the NICU with a PE, I would recommend getting a echo,
And I assume you need
a formal echo. Yeah.
I guess I was going to say too, I've definitely seen negative cardiac biomarkers with signs of RV strain on the echo. So just because you have negative cardiac biomarkers does not mean they don't have a submassive PE. So
It's a great question though, because it's not like a protocol, right? So just not getting a PE or a TTE on everyone with a PE, that's a waste of money. So that's a great question to ask, is like when should we be smart about ordering things? So third case, the last one.
Go back one thing real quick.
Yeah.
So let's say you're that resident that gets called to take care of this patient. Let's say they're on the floor and for whatever reason. You want to give TPA, obviously. Danny's giving you the dose. How do you give it? And in what situation do you give it differently? I think I'm going to ask Claire not to say it because I know Claire knows this because we talked about this when she was on service. Anybody besides Claire, give me the answer. How do you give TPA? This person's hypertensive. You want to give 100 milligrams. The nurse is asking, okay, how am I giving it? Oral, IM, IV, okay. Over how long?
Fast.
Okay. Anybody else got another idea?
2 hours.
Perfect. So in this situation with the person not in cardiac arrest, we actually give the medication on hang it and it goes over 2 hours. We, for whatever reason, like to still push 10 milligrams. The first 10 milligrams we push and the less than 90 goes over 2 hours, but there's no data that really shows that. So really it's hanging it over 2 hours. If you have a situation where the person is either arrested, peri-arrest, right? You're losing a pulse, you push the 100 milligrams of TPA. You can either do it all at once, or you can do it in 250 milligram boluses, depending on how quickly pharmacy is making it. But it is a push. And if the person's arresting and you push TPA, how long do you have to then code the person for to give them TPA the chance to actually work? Anywhere from 15 to 30 minutes. So you are coding the patient for another half hour. So just know that. This is not a situation where you push TPA and you're like, all right, we've done another round of 2 minutes of CPR. They're not back yet. Let's call it. You are committing the patient to another 20 to 30 minutes.
Great. And that's a super relevant point, because you guys will all be in codes where you're thinking about pushing TPA. And once you do it, you owe it to the patient to give them enough compressions to actually circulate the TPA throughout there.
I'm sorry, one more question. In this scenario, do you stop the heparin when you're pushing or when you're running it? TPA?
So you'll stop the heparin, you'll infuse the TPA, and then pharmacy has a protocol that will restart the heparin.
Great question. That's like an actual logistical question, which we don't often ask. Excellent.
If we gave Lovenox,
Just go for
then just, we have no, that's kind of the downside to the Logan offices, that you can't
Just
just
go
turn it
for it.
off.
All right, third case. Does anyone know who the painter of this image is? I would be extremely impressed. I don't know it, but I'll be extremely impressed if you guys do.
Is it Bob Ross?
It is close. It's not a Bob Ross classic. It's not a happy squirrel or a cloud, but we'll eventually figure it out. Oh, I didn't actually click on it. All right. So shortness of breath. There's a theme. So metastatic breast cancer. This person has a history of PE, 3 days of increasing dyspnea, fatigue, and dizziness. Chest pain on the day of presentation. Says she missed doses of her dalteparin and also said she gained a lot of weight over the last 3 months. So she has metastatic breast cancer with mets to the lung. PE diagnosed 1 year ago, treated with dalteparin DIT. And so from that HPI, what are the 2 really big history clues that this lady has a new PE? Okay, so she missed doses of her dalteparin. And then what's another history clue for this person that she may have a new PE?
She has a reason to be hypercoagulated.
Say,
She has a reason to be hypercoagulated.
perfect, yeah, so she got a history of PE, so most likely thing to happen again. And then actually a third one too, is that she also has weight gain. And so a lot of our anticoagulants are dosed based on weight. And so if a person has a significant weight gain, it's possible they're now subtherapeutic. But yeah, history of PE and missed doses of dalteparin should be the 2 top things you're asking any onc patient who comes in. Prior mastectomy, no recent surgeries, no alcohol, tobacco. Workup. Notably, this lady's vitals are essentially completely normal. Her exam is also completely normal. Her labs are completely normal. Does this person need to be admitted?
Did we do a CTP to confirm, or are we saying just before we know?
We did not do a CTP. We're going to do it now. Great. So you actually worked her up before sending her home. Okay. You called me on my question phrasing that. Okay. So here's the CT. If anyone can identify what PE is, you have a free mug in our office.
I didn't agree to that, but okay.
Oh,
Claire said a word. Claire, where is it?
it was, I guess, like lower right. I saw.
Yeah, perfect. So Claire picked that up nicely. So what Claire was looking for is, right, where is the color not that? Pretty simplistic, but right here, you can see that the color in that right lower lobe changes. So I would encourage you guys, if you're getting a CTPE and the read's not back yet, try running through it yourself and see if you can identify the PE, because over time you will get better at picking up where these things are.
And what is that finding called? What's the technical term?
Technical term for the CT finding that we're looking at.
This segmental.
So we're looking for simpler than that. It's a filling. Right.
I was gonna say that.
Perfect. Yes, that's a filling defect. So when you see a filling defect, the correlated diagnosis is PE. So small burden of PE in the right lower lobe without right heart strain or lung infarction. So Claire is a radiologist at this point. Nice job. So case continued. So the painting in the upper right corner is by an Italian artist named Caravaggio. And does anyone know why I would have picked a painting by a person named Caravaggio? Great, love it. So started on a heparin drip, got transitioned to appropriate weight-based dosing with dalteparin, and then the team had a discussion about whether or not to put her on a different medicine. So in April of 2020 of last year, a trial called Apixaban for the treatment of VTE associated with cancer came out, and it was the Caravaggio trial. And so this is named after an Italian painter. I don't know why they chose this name. I think it's an Italian group of authors, which makes sense. And what they looked at was patients with malignancy who had also a VTE, whether it was a DVT or PE and it was acute. They randomized them to Apixaban or dalteparin times 6 months. And they found that recurrent VTE occurred in 5.6% of patients in the Apixaban group and 7.9% in the dalteparin group. And so this study was a non-inferiority study. It wasn't to look at which one was better. And so essentially the conclusion was that Apixaban is non-inferior to dalteparin for the treatment of malignancy-associated VTE. And then there were similar rates of major bleeding, which is a thing that everyone was always concerned about with the DOACs. So when you guys are doing your meta-onc rotations going forward or have patients in the hospital who have been on dalteparin or something like that for an extended period of time, it might be worth bringing up your pharmacist whether or not they're now a candidate for a DOAC, because we have evidence to suggest these people do okay. In this lady's case, it turned out her weight was a precluding factor to getting a DOAC, and so she ended up going back out on All right.
So, one quick thing with that, so this was actually not the first study for apixaban, it was actually the second study that was published about apixaban, but rivaroxaban and edoxaban also had studies looking at this. There are a couple of caveats, so as Danny talked about, weight is one of them, right? So people that have higher BMI, specifically BMI greater than 40, or absolute, kilos are greater than, I think it's 150 kilos, something like that, you get really concerned about bioavailability of these drugs and actually absorption and appropriate therapeutic range. And so for those patients, usually you have to think about whether their cancer, which I looked in more of their weight, if they're not cancer, potentially the other thing to note about these studies is that there was increased bleeding seen in a couple subsets of patients. So primary GI malignancies, especially distal upper GI, so distal esophagus, gastric area, but definitely all primary GIs and what it's lead out to is a larger incidence of GI bleeding. So you got to tailor that. And the other thing is not all of these studies include patients that have known brain metastases. And so another thing to kind of just think about as far as what that looks like. Obviously, brain metastases don't like anticoagulation, period. But, and again, part of this could be where does your patient live, where do they go get care? Because if they're on a DOAC and they're going to always come to the university, we're going to have reversal agents here versus them living out in Pueblo and going to Parkview or whatever, and who knows
Wherever people in Pueblo get care. Pueblo does an excellent job. All of our surrounding hospitals do an excellent job. All right, that was it. Thank you guys. So just to review real quick what we learned about today, so I can get the exit sign. We reviewed diagnostic criteria for massive PE, so shock or a systolic drop of greater than 40 from your baseline. Discussed the PERT service, which you excuse me, I did it again, which means that you guys should be thinking about this if you have patients with submassive PE in the hospital. We talked about the Caravaggio trial and how apixaban may now be our go-to for malignancy-associated VTE in addition to edoxaban. And then talked about right heart strain on CT, so reflexive contrast, an RV that's greater than your LV, or a PA that looks large. Thanks, guys.